So I'm very pleased to first to introduce Natalie, who will give us a good briefing.
Thanks, Marlene. Okay, so we have a situation in which we're now heading into the fourth year in a row of 0% sort of global budget increases, so budget freezes for hospitals. And that really understates the situation, because if inflation is running at around 3% per year, you know, a little less last year because of the drop in oil prices, but generally over the last 4 years, 3%, 2%, et cetera, then, you know, the cut over the last 3 years is 10% in real dollar figures, 10% of hospital budgets. So you're understanding what I mean. If your income does not increase, but inflation goes up, your buying power goes down. And so real dollars are inflation adjusted dollars. That's normally how you measure things because it's a truer measure. And so in real dollar terms, our hospitals have seen about a 10% cut just in the last few years. For 5 years before that, their funding increases were less than the rate of inflation. So they weren't zero, but they were still less than the rate of inflation. So for 9 years now, this is the 9th year in a row, we are seeing real dollar cuts to hospitals in Ontario. This is after 20 years of hospital downsizing and shifting care to the community and so on and actual real cuts as well. And so each year we're seeing pretty significant hospital cuts, and every year those cuts bite ever deeper. And we're now at a point where the cuts that we're seeing are becoming devastating, where truly I believe that public health care is being unwound in quite a purposeful way. And every service that is cut from our local hospitals is being privatized. And it's a real problem. In the small hospitals all across this region, there have been major cuts. And usually they'll do it sort of one big slew of cuts every few years. So for example, Perth and Smiths Falls Hospital, the last 3 years has lost 12% of its remaining hospital beds. That's 1 in 8 beds gone, right? 1 in every 8 beds left gone. Probably, you know, this year or next year, they'll have another big cut of 10% of the remaining beds, you know? And this is happening place after place. Winchester, big cuts. Almont, cuts. Brockville, the birthing unit is currently under threat. I'm trying to think of all the hospitals in this region. Renfrew, birthing cuts. In fact, they closed it down. And even though the hospitals on the way to Ottawa from Renfrew themselves have reduced the hours of their birthing units, forcing women to travel further. And in Ottawa, every one of the major teaching hospitals is facing big cuts now, and actually all of the hospitals. So virtually every hospital has been, and I should say, sorry, I didn't want to miss it, but Prince Edward County, the Quinte area, massive cuts, devastating cuts to both the Quinte West, the Trenton Hospital, and the Picton Hospital, to the point that the Picton Hospital is now down to maybe 10 beds from what was a viable hospital. Virtually every program has been closed down there, and that hospital is teetering on the brink of total closure. Ditto with Trenton. There's still more services. We've saved the emergency department repeatedly from being closed, but you know that they want to close down those hospitals. They absolutely do. And then here in Ottawa, we were just hearing from the workers in the hospital. More than 400 staff positions have been eliminated in the last 3 years.
No, 3 months. Since January.
3 months.
400 RN positions in Ontario.
No. Just at the Ottawa Hospital.
Yes,
Thank you.
400 staff positions. That's nurses, health professionals, support staff. So multiply that by 2,000. Most of them work about 2,000 hours a year, and you're looking at, what is that? Eight and 1, 2, 3, 4, 5, 6 zeros. 8 million?
No.
400 times
Yes.
2,000, 8 million.
It's a lot.
Of
Bad.
patient care and support staff, support hospital support, which is always has been the front line for privatization and cuts. But of course, no hospital could possibly run without those services, feeding patients, transcribing the records, cleaning the hospitals. I mean, it is for a patient vital to their quality of care and quality of life and existence in the institution, but often considered disposable and the low-hanging fruit to cut and privatize. Disgusting terminology. I hate that. The low-hanging fruit. Come on, really. That's not only people's jobs, but also vital. Feeding patients, taking records, transcribing records accurately. In hospital information services, all of those things. And now, of course, systematic. I think systematic destruction of the RN workforce, which is a quality of care issue, but many of you are from labor, and this isn't the Health Coalition's job particularly, but I'll say it because it's my personal belief system as a woman that women entered decently paid workforce a lot in the public services, and the nurses and the teachers led the way. They organized into unions, and they spent the last 100 years or so trying to improve conditions, democratize the workplace, and achieve a standing for women as professionals, which is now being systematically dismantled. I think it's fair to stand up for those achievements and not allow them to be rolled back half a century or more through what they're calling restructuring, which is just cuts. Anyway, so this is systematic. The cuts are massive. And I should say, in addition to the 400 some odd staff positions cut at the at the Ottawa Hospital, it's more than 100 beds in the last few years. It's whole departments all across the hospital. Virtually every department in the hospital, if not every single department, have seen cuts, serious cuts to clinical care and vital support services and health professional services, and also very, I've forgotten what I was going to say. What possibly else could I have been talking about? I'm not sure. Cuts to staff, cuts to beds, cuts to every department.
Every service.
Oh, and privatization.
Yeah.
Sorry, wholesale privatization. So they cut the endoscopies for example. There is nowhere else to pick them up except for the private clinics in Hull and Ottawa, where they charge patients user fees on top of billing the public tax system, or OHIP, for those services. But everywhere, CHEO is seeing cuts, the Queensway, Carleton is seeing cuts, the Royal Ottawa is seeing cuts. I mean, major cuts everywhere across every hospital. And there's no choice, and that's only going to get worse if, as planned, every year there are budget cuts to hospitals, real dollar budget cuts through to 2018, which is the current plan, and perhaps even further, even longer than that. And in addition to that, sorry, I just want to, and there are two things that I just want to deal with. One is, there are really only two defenses that the Minister of Health and the government uses for this. One is that they say, oh, these aren't cuts. This is transformation. We're moving care out into the community. The truth is that happened 20 years ago in Ontario, 15 years ago, 10 years ago, but it's already happened. We have the shortest average length of stay. That means we kick patients out of the hospital faster than virtually anywhere else. We have the fewest hospital beds left of any jurisdiction that I've been able to find. We're at the very bottom of every province in Canada, by far, not by a small amount, by far. We're at the bottom of the OECD, that's every industrialized country in the world, quote unquote industrialized country in the world. The only countries that have fewer beds than we do are Turkey, Chile, and Mexico, right? All of Europe has more beds than we do. I mean, we have cut our hospitals and transferred care out to the community. That happened. Any claim to that right now is just a lie. What we're closing is operating rooms. We're closing emergency departments. We're closing, cancer care. We're just up in Kenora the other day. They're closing chemotherapy 2 days a week. This is not care that's being transferred to home care. It means that people have to drive to Thunder Bay to get their their chemotherapy. I mean, it's a total lie to pretend that this is transformation. This is the outright cut, serious cuts to serious critical care beds, acute care beds, complex continuing care beds, care that is required and needed in public hospitals. In addition, it's the privatization of whole sections of care from which the private sector actually thinks they can make some money. So diagnostics, the easy ones, the ones where patients can walk in and out, the fast surgeries, the easy ones, of course, not going to take the people who are all, attached with tubes to all kinds of equipment and so on. They want people that can walk in and walk out, do it pretty fast and make some money off that procedure, that kind of thing. That's what this is all about. And the other thing that they are claiming, the hospital leadership and the ministry at times claiming, that this is, that we have all these bed blockers or ALC, alternate level of care patients, and if we just cleared them out, we would be able to, well, some of them say shut the beds behind them. That's Tom Clausen and, the hospital executive sort of leadership. And some of them, pretend that is evidence that we have inefficient hospitals, and, that's sort of what they raise, to sort of sidetrack opinion every time you talk about hospital cuts. Well, the truth is that the Ontario hospitals do a survey every year of their so-called ALC patients. And they do it actually every few months. And, for years now, every year that I can remember now, for half a decade or longer, about 60% of those patients are waiting for a hospital bed. Alternate level of care actually means that you're just in the wrong type of bed. It means that you actually require a different level of care than the bed that you're in. So you might be in a medical or a surgical bed, but you're waiting for rehab, like inpatient rehab, but all the rehab beds are full. So that's an alternate level of care patient. They're not waiting, they shouldn't be moved out of hospital, they should be moved in hospital to another type of bed. So 60% of those patients are waiting for convalescent care, palliative care, rehab, medical or surgical bed, whatever. They're just in a different type of bed. And the rest, 40%, are waiting for long-term care. They're assessed as needing long-term care. But because hospital patients are always the top of the wait list, because the whole system is geared towards moving people out of these, overcrowded hospitals. Well, so the truth is that the people who are in hospitals waiting for long-term care and unable to be placed are there because their care needs are too heavy for any existing long-term care facility in the area. They are people who used to be considered chronic care patients. They would be in publicly owned, and operated chronic care hospitals. And there's no reason why they should be moved into a private for-profit, a majority of long-term care is privatized facility. The reason they want them out is because in long-term care you have to co-pay for your bed or your room, right? You have to pay for your medications, which you don't in hospital. You have to pay for your lab tests. It's because care, the publicly funded part of it, is severely rationed. The staffing is much lower there, so therefore they're cheaper. But it's not comparing apples and apples. If you were to have equivalent levels of care, the cost would be the same, of course. And so that's what it's all about. It's about cheapening care by moving everyone who used to be chronic care, or complex continuing care as they call it now, out into long-term care homes. And they are assessed as ALC even though there's no home to take them in most cases. And if they're temporarily on the ALC list, well, it's because they will be placed fairly soon. And that's happening everywhere. So this notion that there are, whatever they're saying now, it's 4,000 or 7,000 people blocking hospital beds that are an indicator of hospital inefficiency in Ontario is a total sham. And there's no question to me that every hospital CEO has to know that. If they don't know that, it's bizarre. They do know that. So the fact that they are echoing this messaging line is an indicator of two things. One is that they have to sign communications agreements with the local health integration networks, the government appointees who plan health care for each region. That's one. They are required to do that as a condition of their funding. And so whatever the communications agreement, true or false, manipulative or not, they have to follow that. The second is that this government has, more than any in history, used its power of sending in supervisors, government-appointed supervisors, to fire the CEOs and wipe out the hospital boards and replace them with their own appointees when they are not compliant with the cuts. And they've done it all over Ontario. And so the hospitals are heavily censored now. So unlike in the Harris era of hospital cuts, which was the last major round of cuts that we saw, and they weren't actually as major as these cuts, frankly. The hospital CEOs, the hospital leadership has been reticent to speak out publicly, making it much harder, and in some cases, they've actually put out a public message that makes it seem like the cuts aren't such a big deal. The most recent one is that, oh, we're just eliminating vacant positions.
Mm-hmm.
Well, let me ask you this, how do you save money by eliminating a vacant position? Obviously, if the Ottawa Hospital is going to cut $14 million by eliminating vacant positions, the positions can hardly be vacant then,
Right.
can they, right? I mean, it's just utter nonsense. Those are positions that were filled up until, whatever, 2 weeks ago when they decided not to fill them, and now they're eliminating. It's a game that they're playing, and we just need to call them on it. And it's, you know, nobody, when you think about it for 1 second, you know, thinks that you can save money by eliminating a vacant position. You just have to cut through the nonsense, right? And in a lot of cases, there are agency staff or people temporarily doing that work. And when they eliminate the vacant position that someone is actually in, that work is eliminated and that care is eliminated from the hospital. So that's the latest sort of, it's not even window dressing anymore. It's just lies to cover up for what are real cuts. I don't know if the health minister, who may be well-intended, he seems well-intended in Ontario, knows this, if he really believes what his advisors are saying or what, but who cares? Because our job now is to cut through this and really, one, knock down the nonsense, and two, build the kind of resistance that is commensurate to the cuts, to the threat that we're seeing. So 400 positions in Ottawa, the Royal Ottawa Hospital, hundreds across the other hospitals if you total them up. In this city alone, hundreds of hospital beds, countless services, privatization of clinical care. To me, that calls for major response, not just a few hundred people outside handing out some leaflets, but the kind of response that is commensurate to a government doing this. You know, if this was the Harris government, we would have had thousands of people in the streets, and I think part of it is just because it's a Liberal government, people are a little less likely to immediately think that what they're doing is such a clear privatization agenda. But while they may have announced they're privatizing, Ontario Hydro, they actually are privatizing the hospitals piece by piece by piece, and now in an accelerated way. And my last thing is, in addition to that now, their new plan is to privatize the last remaining public and not-for-profit parts of the home care system, and hand them over to for-profit companies to run, and provide the funding through a type of medical savings account. I won't get into that, but it's devastating. It actually sets up the system by which you could unwind all of public Medicare, including the insurance system if you so chose. It's a very bad move. And so we're just talking about taking the health minister maybe to Manitoba and trying to show him a model of a public nonprofit home care system that works, to give a different alternative. So we're working on that, but we've combined that in with the cuts issue. So I asked my board, could we have a special emergency meeting when we heard about the home care situation? We were fighting local hospital cuts in 45 or 46 cities, towns and cities across Ontario, and we realized very quickly virtually all of the hospitals are going to end up in deficit. We can't run 155 campaigns. There's only 2 of us in the coalition office and thousands of volunteers, but I mean, it's not doable. So what are we going to do to stop this? And we agreed to hold regional days of action, so much bigger events. We're hoping to move from hundreds of people out protesting in each region to thousands. That's the goal here. And to just escalate it. We'll just keep doing it. We'll build and build and build and build until the government goes, mercy, you know, what do you want us, what's it gonna take to make you people shut up? That's the goal here. It works, and we've done it time and time again. So my last comment is this: we can win. In the last year, we stopped the closure of the thoracic cancer surgery in Windsor. Just in the last few weeks, we stopped the closure of the birthing unit in Leamington by taking pregnant women to Queen's Park and parading them around the legislative building and holding press conferences and so on. You know, talking about how they didn't want to give birth on the side of the road. Who couldn't empathize with that, including the MPPs, and, you know, really making visible the cuts. We've rolled back the P3s John and I were talking about in a way that they haven't in any other jurisdiction. We stopped the closure of the small and rural hospitals across Ontario. We've saved, just recently, we just saved the Trenton Emergency Department again. I mean, we absolutely do succeed, but what it's gonna take is a person-to-person appeal, like, you know, the kind of appeal where unions phone bank their memberships or hold teletown hall meetings or individually reach every member with a leaflet, where in the community we hold lead-in events that get media, and we invite people out where we engage all of the social movement groups and ask them, will you make this a priority just for, you know, the next month? Help us make this thing rise above the noise. Help us, you know, really make something that can't be ignored by the Wynne government. You know, just try and push it a little further so that we're moving from a few hundred to a few thousand. And we know, you know, we might not win, but the truth is, if we don't fight, we definitely won't win. And so we don't really have a choice. And so that was my message. And so Dr. John Lister is associate professor at Coventry University and author of 2 books on global health reform. Did his PhD on global health reform, and founded London Health Emergency, which is sort of like our counterpart in London, and sits on the steering committee for Keep Our NHS Public. That's the national health system, the British public health care system, and is an expert in health reform. We're so lucky to have him. He's been traveling around for 2 weeks with us, looking at what's happening in Ontario and giving us some analysis and some context to understand it. And
thank you very much. Nice to be here. I just thought I'd bring the changes a little bit. I've just been giving lists of issues and so on. I just thought some of the language, Natalie touched on some of it, some of the language that's used, we just need to start to puncture some of this stuff because it's just mad. Back home when they want to close hospitals, they don't never ever admit they're closing hospitals. The phrase they use is reconfiguration. Reconfiguration. Now reconfiguration suggests that you've got basically the same amount of services but in a different formation. But actually what they're doing, they're taking whole hospitals out of the frame. And then of course linked into that they have the phrase restructuring. Okay? And the Conservative-led coalition government from 2010 engaged in what they called a restructuring of the National Health Service, in which they basically smashed to pieces all the existing management structures and accountable structures and put together a brand new structure. This was the biggest reform ever. The NHS was formed in 1948. Right? The piece of legislation that formed the NHS was only 1/3 of the size of the piece of legislation they brought forward in 2010 to allegedly restructure it. This was a complete and utter demolition job and recreating it along lines. So we now have local commissioning groups, which are the equivalent of your LINs, I suppose, in a way, the nearest equivalent that we've got. And they are charged with finding ways of breaking up different services and putting them out to tender. So, and to any qualified provider, okay? Nobody's defined what qualifications mean. You know, what qualification are they required to have? My wife has an uncle, Colin, and he was an electrician by trade. Anyway, a number of his colleagues had some kind of professional qualification at the end of their name, little letters at the end of their name, and he got a bit fed up that he didn't have the same. So he used to describe himself as Colin Ravenscroft, TLB. And eventually somebody asked him, Colin, what does TLB mean? 3 lengths of the bars, so you got a swimming certificate. It's a qualification, you see. So any qualified provider, and if we look back at when Margaret Thatcher began to privatise the support services in hospitals back in the 1980s, which is when I started in London Health Emergency, the very first campaign we ran was against that privatisation of support services. And back then, the competition was purely on price. Now everybody knows if you pay cheap, you get rubbish, you know. It's the same all over, you know. Nobody with big money ever goes into a fast food burger joint for a quality meal, you know. They know that actually if it's cheaper, but you don't get the quality meal. And it's the same with hospital cleaning, which is a labour intensive job. And it's the same actually with nursing. It's a labour intensive job. You take the quality out, you take the qualified nurses out, you reduce the quality of what you get. But anyway, coming back to some of these phrases, care closer to home, right? Care closer to home means basically do it yourself. It basically means care in your own front room by yourself, by one of your relatives or a neighbour, you know? And we're not going to care in the community, right? In the community. What do you mean? Where in the community? It means we don't know where the care is going to be, and maybe somebody will draw up a plan after we've closed this hospital here, right? And again you have these phrases chucked in. We want patient choice as to where to get their treatment. Well, you ask most patients, where do you want to get your treatment? It's the nearest possible place that can guarantee a quality of care. So the priority should be raising the standards of the existing hospitals to ensure they can get the quality of care they need, except for obviously highly specialised services and so on. Everybody accepts. You don't want cancer care at the equivalent of the corner shop. You want if you're going for cancer care, you want to go to a centre where people see lots of patients, they've got lots of experience, they've got all the equipment that they need and so on. That's understandable. But for many of the things that people need acute care for, you know, the various things that the smaller hospitals still deliver acute care around Ontario, then the reality is that they can deliver that care. They need the resources to make sure they can do it well. What they don't need is those acute services to be cut one by one, and everyone to have to trek into Ottawa or to Toronto or into the various big centres to get their care, because these centres are not resourced to deal with that. People are dislocated from their homes and their environments. Sometimes if they're admitted to hospital, it's very difficult to discharge them home again because of the distances and so on, the lack of support when they get out. So these are big questions. So choice means quite the opposite of what it appears. So instead of really being given a realistic choice, it only applies to the most minor elective operations, where it doesn't matter if you ride a long journey to go and get it and come back again or whatever. But everything else is the opposite. And integration is the other one, right? Integration. What do they mean by integration? Local health integration networks, LINs, right? What are they doing? They're smashing services up. They're actually breaking things apart. Instead of bringing things together and focusing care where people are, they're actually lifting people up and forcing them to travel to services which aren't properly provided there either. This is I don't see any sense at all that the LINs have any real grip on it. And if you want an example of that, look at the emergency room response times in the local hospitals here, where they've just put, I've just looked these figures up because this astounds me. Coming from England, we had an investment programme from 2000 to 2010 in England. The Blair government put substantial year-by-year increases in funding into the NHS, the National Health Service, which more than doubled health spending over that 10-year period. And the aim was to drive up the share of wealth being spent on healthcare in England towards the European average. We were way behind, to drive it up towards the European average, because at that point there were huge problems, huge queues for emergency treatment, huge queues for and delays with accessing elective care and so on. So the idea was to tackle those problems. And they put the money in and they reduced emergency room waiting times in England to a target of a maximum of 4 hours for 95% of people to be seen. 4 hours, okay? What's the provincial target in Ontario? 8 hours. What's the provincial average in Ontario? 10.7 hours. What's the average what is the figure, the achievement in the hospitals in Toronto, the main hospitals in Toronto? Well, in this area, 18.5 hours at Hawkesbury, 15 hours at Ottawa Hospital, okay? 15 hours, okay, but that doesn't fully state the problem, because if you look at the LIN's own board papers, the LIN has these performance, and they're saying performance is improving in in the LIN, because the time in ER for admitted patients, that's the acute, seriously ill people who arrive in an ER and need a bed immediately, the time in the ER for 90% to go through, 25.2 hours, right? Now, I'm told, Natalie was saying, well, people won't be that interested in that because they're used to it. I don't, why are people used to this? This is desperately poor by almost any international comparison. This is really poor. And they're congratulating themselves because the LIN target is 25.8 hours, right? The target is for people to be there more than a day on a trolley or a stretcher without a bed for 90%, before 90%. This is ridiculous. It's a target that is actually miles off what patients need, but it's a target which they've only just achieved. And they're now congratulating themselves and getting it down to 25 hours. Now, if you're one of those people, and that's 90%, so 10% wait longer than that, right? So if you're one of the 10%, 30 hours, 36 hours on a trolley waiting for treatment, maybe you know someone who's been in that position. But, why are people accepting this? This is just awful. This should be a source of public shame, and the chief executives are running systems like this and claiming that they're succeeding, claiming their telephone number salaries for this, should be actually called to account and hauled over the coals. This isn't a success, this is a disaster area. And they're planning to run hospitals at 90 to 95% capacity. Anywhere in Europe, almost any other civilized country, it's 85% is recognised as the maximum you can do without serious disruption. If you have a serious uptake in winter illnesses or something, then you've got capacity to deal with that. It also means that the nursing staff are not run off their feet trying to deal with constant flow of seriously ill patients with nobody actually allowed to recuperate before they're shoveled out and either dumped into the bin of ALCs or actually discharged home whether they're ready or not. You can't run hospitals like this. Permanent crisis. And what about bed occupancy? Look at the situation here. Again, I looked this up. This is the most May the 20th figures at the Ottawa Hospital. 102% occupancy.
We've been like that for years.
Well, exactly, being like that for years. So you're organising for chaos. Okay, you're planning a crisis regime. Now, this is madness. This is just not a way to deliver quality care. And they strut about in their, flash suits and whatever, and telling you everything's okay, and it clearly isn't.
They just told us today we're okay.
Right, yeah. Just imagine them on one of those trolleys. How long,
No, if they're any type of MP or whatever, there's a back door at the
Of course there is. Of course there is. That's why nobody ever
So
knows.
there's no one,
It's
they're not.
it's like back home whenever the Queen visits a hospital, they always say, oh, this always smells of paint.
Oh, I know, yeah. We have a special room for
Yeah, exactly. And they have to install special toilet facilities because the Queen apparently has some continence problem, and she never has to be more than about 15 feet from a toilet. Anyway, so they have to carefully plan the route through the various buildings. Anyway, so the royal family, what about it? Anyway, so I just think that these things are really important because, on the one hand you have a rhetoric which is trying to persuade people everything's good. On the other hand, you have a reality which is actually getting worse all the time. Every time you lose a registered nurse position, every time you downskill the jobs, you make it more difficult to sustain the standards for the people who are left behind. You pile the pressure on, pile the stress on, people get demoralised and leave. You have to then bring agency staff in, which is a big problem we've now got back home, because we've just had 5 years of freeze after those 10 years of growth. 5 years of freeze, and it's all starting to unravel, and we're starting to see precisely the predictable things. Waiting times are going back up in ER. Ambulances are back up out of parking lots trying to deliver patients and unable therefore to meet their response times, and their performance is falling off. Patients can't be discharged because there isn't anything outside to look after them. These things are not that dissimilar. The circumstances are quite different. The country is much larger here, but actually some of these problems are pretty much the same. But it's utterly predictable. If you squeeze, freeze and cut spending in hospitals, you are going to get those results. And if you set out to manage a hospital at 90 to 95% occupancy, you're going to get 100% or more patients occupying it. That means 2 to 3 people per 100 beds are wandering around or being driven around or led by a named porter around on the trolley looking for a bed. And that is not a way to run a hospital that's going to deliver quality care to patients. And I just would add the other point, which I didn't make this morning, you add in mental health to that. You know, over-occupied wards in mental health are danger to patients and to staff and an utter scandal. And there's no way whatsoever that's a therapeutic environment to patients. And to actually pretend otherwise is just absolutely irresponsible. And again, the norm for that should be no more than 80 to 85%. If they're running above that, that is a crisis, and that should be, you know, ministers should be stepping in on this and actually ordering these hospitals to sort things out. And then, of course, you get the other point. We had a report 2 years ago, the Francis report, on a major scandal, failures of care in Mid Staffordshire Hospital, which is in the West Midlands in England. This was in the mid-2000s. The report finally came out about 5 years after, 4 or 5 years after the events that it talked about. But there, the management had tried to save 10 million in a year by actually choosing to cut professional staff, qualified staff, because they saved more per staff sacked than if they sacked support staff. So that's what they chose to do. So they ran the staffing levels down to some of the lowest ever seen in our National Health Service. And the predictable thing happened. All kinds of patients went without care. Relatives were horrified. They got banged onto the local paper. The local paper started a campaign. Eventually there was an inquiry and the whole thing. And now they're trying to close the whole trust down, the hospital trust down, to avoid the continuing reminder of what happened there. Anyway, the Francis report said that managers who find themselves in a situation where they cannot deliver quality care on an ethical principles should actually not just accept it and try and go ahead anyway, but should speak out and put pressure back on the politicians. Right? That's absolutely correct, and that absolutely ought to be the way. And if these people are claiming these salaries but not taking that responsibility, then they're just demonstrating they don't care at all for either care services or for patients. And all they're looking at is the bottom line of their salaries rather than the actual services they're delivering. So it really is important that we have campaigns that flag this up. And it really is important that people just don't take it for granted. This is all that can be done. It doesn't have to be this way. It didn't have to be that way in England. They showed they could do it. Elective waiting times were brought down from 18 months to 2 years for operations in many cases to a maximum of 18 weeks, again by investment, extra staff, new resources, beds opened up and maintained through the winter to avoid winter peaks. And again, we can see as the freezers come back on, that's being undermined as well. And I'll just add one other thing, which is about health service pay. Okay, I think it's not quite the same here because you have had some increase. In England, the increases have been below inflation for 5 straight years, and it means qualified nurses in England are now 16% worse off in real terms than they were in 2010. Now, in places like London, where there's great competition for nurses to fill jobs, and so on, and then you combine these pressures, more and more of them are just walking away. They're just going to find other things to do. They're talented people. They've got qualifications. There's plenty of other options for them. They're just disappearing. Now, this means we are spending millions and millions and millions of pounds on agency staff, you know, which deliver poor quality care because there's no continuity and no links with them. And that again is a desperate waste and undermining the quality of care. So I think we've got big issues here. We've got big issues in England. But you know, I think these days of action should be a cause to say, look, we don't have to take this nonsense anymore. This is crazy. 25 hours in the ER is a scandal. We want resources to bring these services back up to international standards. No, I don't see how the Ontario minister can hold his head up in any international forum and actually, you know, while delivering this. And it just needs to be exposed and challenged. Let's shame these characters, you know, one by one, work around and make sure to keep the pressure up to get the Medicare system properly funded, both at federal and at provincial level, so you can actually get services that you can be proud of, and Medicare be rebuilt again as a service which clearly Canadians can take as a point of pride as better than those characters down south and the shambles they got down there, which cost them 17% of GDP. There's still, even after Obamacare, 30 million Americans without any healthcare at all, cover at all, and millions and tens of millions who are underinsured to the point any major health problem is going to bankrupt their family and cause major problems. Nobody wants to slide down that road. Let's keep Medicare, publicly funded healthcare, extend it maybe to services outside of hospital that are still medical services. That's another useful step forward. But let's have a fight to rebuild on those principles, just as we're trying to fight back to actually defend our NHS in England. Best of luck, you'll be fine.
All right.